Robert Rubinstein here from Syracuse University. He is a political, cultural, and medical anthropologist. He is also the former director of the Maxwell School of Citizenship and Public Affairs.
No, it's the program within the school.
The program within the school. The program being public affairs.
No, the program and analysis and resolution of conflicts.
That was it. Okay. He has worked with and studied with peacekeeping forces in the Middle East. He has done extensive work on these peacekeeping forces, but more recently, he has been working with the medical field and doing community outreach. He's very interested both in the United States and the Middle East. He has worked together with his wife on this as well. And recently published a book, right? You know, last year? Yep. On that. I have two of these books here that I'm going to pass around. This is actually the book that I would like to pass around, is Peacekeeping Under Fire, which I highly recommend that you read. But in the meantime, here are two other books that are also written to edited volumes. One of which we worked on together. So with no further ado, thank you so much. And I'm going to pass this one this way, up that way, and you guys in the middle hopefully will come to you as well.
Thank you very much, Clem. This is about as loud as I get. I don't usually read my papers, but I understand that the culture of this particular place is that if I'm still talking about anything at the time you have to leave, that you'll just get up and walk out. And so I'm going to read this. I apologize for that. I've practiced it, and we'll see how that goes. But anyway, I want to thank Clem for that introduction, thank Professor Reese for inviting me to visit the Center for Regional Studies. Thank Keith Himmer for all the logistical support that went into this. So my topic this afternoon is culture, interagency dynamics, and health in the Middle East. And my goal today is to cover 4 interrelated areas. But before I do that, I want to say a little bit more about my background. As Clem said, I'm an anthropologist with a degree in public health. And I also have been conducting research on political anthropology. This has brought me into studying peacekeeping operations beginning in the mid-1980s. And I've brought that together with the work I've done on public health, which also began for me in the 1980s. I've lived in Egypt for 5 years, worked there since the late 80s. And I've worked throughout the Middle East, especially in Sudan, Palestine, and Jordan. And when I eventually get to the health examples towards the end of my talk, they will be drawn in part from that work. So the 4 areas that I want to cover today are, first, I want to clarify what culture means and why it's important and how to approach it. And once I do this, I'm going to discuss some of the ways in which culture affects cooperation among and between different kinds of organizations, military, civilian, international agencies, and non-governmental organizations. Then I'm going to expand those ideas to examine the ways in which this affects the cooperation of international agencies with local cultures, and my examples will come from the Middle East, which is where I'll finally turn in the 4th to look at medical pluralisms in the Middle East and bring that all back together. So let me begin by talking about approaches to culture. So people engaged in what I call post-conflict stabilization missions face cultural challenges, both in relating to the people in the area in which they're working and in working effectively with others serving in the missions, both military and civilian. So their ability to work with others in the mission and to work with local populations is essential to the mission working smoothly and achieving its goals. Today I'm going to call the interactions that take place among the various international actors horizontal interoperability, and the interactions that take place between international actors and the local populations vertical interoperability. The practical need to understand and overcome the difficulties of civilian-military interaction has led to studies that highlighted the differences between the military and NGO actors and analyzed these differences in terms of the problems they presented for the mission, or they've elaborated ways to overcome those difficulties. The bulk of this work describes or prescribes various mechanisms for smoothing the interaction between civilian and military people in the field through joint training, in-field coordination, developing shared operating procedures, and so forth to ease likely points of tension. A relatively recent development in this effort has been to use the concept of culture as a lens through which to examine problems of horizontal interoperability and to account for the points of tension among actors in complex missions. I want to suggest a framework for taking into account local cultural factors that affect coordination and cooperation among and between missions and local populations. Now, one principle that I base my analysis on is that interaction with local populations and interaction among mission staffs of all types is not isolated from one another. I therefore approach the issue of vertical cultural challenges in the same way that I do horizontal challenges. And this leads me to look at several different ways in which we can talk about culture. Now, culture has been defined in a wide variety of ways and for many purposes. I want to speak about three of these with you today: what I call traveler's advice, the dimensional analysis of culture, and understanding culture as the creation of meaning. Now, traveler's advice provides kind of a list of facts about the other group's way of dealing with the world, and a basic list of things that a person going to engage with members of another group or society should do or not do. It focuses on things like how to count in the other group's language, how to recognize divisions that are important among members of that group that may not be obvious to the person going to meet them. And classically, it gives advice about what kinds of things, gestures, and so forth to do or not do. You've all heard these things about the soles of your feet, or which hand to eat with or not eat with, and so forth. These are stereotyped instructions that focus on the surface elements of culture, and most often on those surface aspects that are different or exotic from the perspective of the person giving the instructions. One example which you'll all be familiar with are the smart cards that are produced, such as the Iraq smart card. Another is the advice, for example, given by the Japanese Ministry of Defense that its personnel being deployed in Iraq should grow mustaches so that they would fit in with Iraqi culture. Now, traveler's advice treats culture as a stable, homogeneous thing that's organized in the form of rules of action, sort of a set of do's and don'ts. So, for instance, it leads to developing lists of differences, such as the dichotomies that are presumed to exist between military and civilian organizations. Unfortunately, the descriptions that they contain have the characteristics of stereotypes, and so they treat culture as unchanging and shared by all members of a group, and they have the force of they lead people to believe that culture has the force of determining behavior. This can have the unintended and untoward effect of giving people who use these guides a very false sense of competence in dealing with members of other organizations or with local populations. Though such a handy catalog of differences is perhaps useful for some purposes, it's inherently limited. And because the cast of characters involved in any particular post-conflict mission is constantly changing, there's no way to adequately give such a list. So that leads to the second way of approaching culture, which is to look at the dimensional analysis of culture, or how people do what they do. Moving beyond the surface manifestations of culture, researchers who study intercultural encounters have developed a number of approaches for diagnosing culture-based differences. As a result, there are many schemes for understanding how and why culture affects interactions among different groups of people. Now, common to all of the frameworks offered by researchers is that they seek to describe a group in terms of cultural styles or dimensions. Importantly, each of these frameworks is derived from some form of empirical investigation, whether it's through ethnographic research, organizational survey research, laboratory analysis, or psychological experiments, usually with undergraduates. 5 of those resulting frameworks come out most commonly, and those that are encountered in the international relations literature are the dimensions of narrative resources, differences in narrative resources and verbal styles, differences between the way cultures take account of context, differences in thinking and reasoning styles, differences in information processing, and differences in the way different groups manage power and social relations between supervisors and subordinates. Now, I'm not going to review each of those here, because that's not the main focus of this talk, but I'm hoping to leave time for questions and answers, and I'll be glad to discuss that. So these dimensions are often discussed as allowing one to array groups along a continuum, the ends of which are represented by different cultural extremes. Perhaps familiar to most of you will be the proposition that miscommunications between people from the United States and people from the Middle East occur because we have different cultural ways of delivering messages. The United States is said to be a low-context culture. This means that we put all of our meaning into the message, we say what we mean, and we mean what we say. We are, in that sense, direct. In contrast, people in the Middle East, according to this kind of analysis, are said to be from a high-context culture. That is to say, they vary their messages depending upon the context in which they're speaking, expecting their interlocutors to pick up meaning and cues from the environment. They are said, in that sense, to be from an indirect culture. Although the dimensional analysis of culture can be a useful way of thinking about difference, it can also lead to stereotyping. Indeed, the example that I just gave relating to high context and low context differences between the Middle East and the United States is false, in the sense that in both places, individuals are more or less direct depending upon a variety of pragmatic considerations. So I don't think that taking a dimensional view of culture is satisfactory when you begin to look at the kinds of health interactions that I'll be speaking about in a few minutes. So the third way is to look at culture as a way of people creating meaning, which is to say, understanding why people do what they do, or do it the way they do it. And for this, I adopt the common anthropological conception of culture that was characterized by Roy and Dendradi as the following. Culture is seen as consisting of a system of meanings communicated by means of natural language and other symbol systems that have representational, directive, and affective functions. I can't go back. I think I'm going to be out of sync here.
Wrong direction.
OK, we can stop with there. Oh, so it's right here. Sorry. Thank you. Have directive, representational, directive, and affective functions which are capable of creating cultural entities and a particular sense of reality. Through these systems, people create meaning that helps them adapt to their environment and structure their interpersonal interactions. Tells them what's normal and what's not normal, and it helps them interpret their experience and helps frame the way people come to feel about things. In other words, culture in this sense is a fluid pattern of beliefs that orients and constrains rather than determines behavior. A culture is therefore not uniform for all members of a group. There's considerable intercultural variation, and therefore one can't rely on a list of traits and do's and don'ts. Now, culture is important because it's the basis upon which people generate options for structuring their actions and creating solutions to problems they face day to day. Another way of speaking about this is to say that culture gives a frame of reference from which people gain an initial sense of their reality and develop their ideas about what is proper behavior in a particular situation. What people believe is real and normal, and it shapes their emotional reactions to those experiences. Characteristically, culture in this sense operates outside of one's conscious attention. It orients and disposes people to particular actions and interpretations, but it does not determine what those actions will be, and it affects all levels of human action, from individual motivation to working with groups. This is a little convoluted, but it's actually a very wise quote from Marshall Solins, who said, just because culture is like a grammar, just because what is done is culturally logical does not mean that logic determined that it be done, let alone by whom, when, or why, any more than just because what I say is grammatical, grammar caused me to say it. So if you think about that for a second, it lists culture as a guide, a frame of reference within which one works. This symbolically based concept of culture is important for thinking about the issues that arise when multiple organizations try to work together to develop the health capacity in places where they may be deployed, or when they work with local populations. So I want to speak briefly about horizontal interoperability and then turn to the vertical interoperability. So post-conflict missions involve many different kinds of actors and thus require the development of a kind of coordinated action or interoperability. Here, cultural aspects of horizontal interoperability become very important. As I said a few minutes ago, many efforts at identifying organizational cultural differences between military and civilian actors use a dimensional analysis of culture, noting, for example, that militaries are hierarchical, closely controlled, and well-resourced, while NGOs tend to be decentralized, operate independently, and are minimally staffed. However, these efforts miss a deeper problem, which is that attempts at civilian-military coordination have frequently run up against disparate meanings and understandings of things like partnership, cooperation, and worldview. And this is exacerbated by the dominance of the military in planning missions, both at the strategic and tactical levels. These intercultural clashes have complicated the search for interoperability. Let me give you an example from my field research. In that research, I have frequently listened to conversations between civilian humanitarians and their military counterparts concerning the need for coordination. And these conversations have a distressing commonality. Regardless of the location in which I was listening to these conversations, they seem to almost follow a script that went something like this. The conversations begin with a profession of respect for one another and of a desire to work together as partners. This is followed by a discussion of the practicalities of operating together, which inevitably reveals differences in preference and framing of the world and of incentives. The stumbling points could be at any level, including the humanitarians' concern for the preservation of humanitarian space as a key symbolic component of their worldview and as a factor of their safety. The military's concern for the importance of a unitary command and control as also a key sense of self-identification. And the disagreements about the proper site for mission activities. At the impasse, the earlier professions of respect and the desire for partnership are often repeated. The conversations are then resumed with an examination of the practicalities only to clash once again. Depending on the patients and the will of the interlocutors, this pattern of profession of respect and partnership followed by disagreement, returning to the mutual admiration of one another, could continue for some time. But nearly universally, the conversations I observed ended with the parties failing to reach genuine agreement. Typically, the military interlocutor would communicate either directly or indirectly the idea that, yes, I want to be your partner and I respect what you do, so long as you follow my lead and instructions. This is not what might be seen as an expression of respectful partnership, but rather an assertion of power, dominance, and control. The interaction illustrates that while it's relatively straightforward to describe and try to accommodate to the surface differences between groups, whether one's hierarchical or not, it is much harder to harmonize the deep cultural differences. Yet it's these deep cultural differences which challenge cooperation among military, NGO, and specialized agency interactions. And it's because of these differences that particularly involve the ways in which people understand and feel about their experience, and thus shape whether or not they believe and feel that they're being taken seriously, that problems occur. The deep cultural aspects of interaction are significant complicating factors in horizontal interoperability. And this is no less the case with vertical interoperability. Among the many different ways in which local culture factors into vertical interoperability, one of the most important issues is the perception of respect, or lack thereof, and partnership between local populations and international efforts. So let me turn now briefly to looking at some of the challenges of vertical interoperability and engaging local cultures. What matters in cultural encounters is less the surface forms that are common to a society, those things captured by what I just described as traveler's advice. What matters most then is that the underlying symbolic reasons for these forms and the cognitive and affective systems to which they are tied. Although there's some use in describing the potential complications that can cause cultural mistakes at the surface, this has to be connected to the deep cultural level. Especially important in conflict and post-conflict situations where people have experienced deprivation and trauma, is communicating in a way that allows people to understand themselves as valued and respected. This cognitive step can help align affective responses so as to avoid the incorrect attribution of motive. Thus, achieving vertical interoperability hinges on the ability to interact with local populations in ways that communicate genuine partnership and respect for the key symbols of their worldview. Moreover, if they are properly engaged, members of the population can serve to assist as cultural instructors or to act as colleagues who have real responsibilities and can serve as the primary liaisons to the local population. Respect and partnership are key symbols in interoperability and must be the foundation of actions and institutions for building health capacities. Local populations have concerns that stem from their histories, whether these are from a colonial period or from more recent experiences of disenfranchisement and violence based upon their ethnic and group affiliations. Effective health development needs to be attuned to how issues of identity and memory affect how local populations perceive those efforts. These considerations go beyond the interpersonal contact that may occur between those working for health development efforts and local peoples. Instead, the question of respect and the question of partnership apply most acutely to the structures, institutions, norms, and the consequences that come along with health development work. I want to turn now to talking about some medical pluralism in the Middle East. and look at the ways that culture affects the development of health capacity there. As with my earlier discussion, it's important to recognize that cultural effects take place on many levels, from the ways individuals think about the source of health and illness, to what they understand health to be, to how they think about and interact with health professionals. Like people everywhere, people in the Middle East share multiple ideas about the source of illness. Some of these different theories of disease vary according to a person's educational level, their social class or occupation, or between rural and urban settings. Indeed, individuals can actually hold divergent views about health and illness simultaneously. So it's important to recognize that some explanations of health and illness link to people's conceptions of who they are. That is, conceptions of health and illness link to their sense of personhood and identity. As well, cultural factors affect how people think about healthcare providers and about health systems generally. And these kinds of cultural factors are seen in local understandings of what counts as good, responsive, and respectful care. I'm going to be discussing two specific infectious diseases with you today and how they're understood in the Middle East. The first is trachoma, which is a chlamydial infection of the eye. And it is the leading cause of blindness, of preventable blindness in the world, and it's endemic in many parts of the Middle East. Trachoma is a disease of childhood, but its sequelae are seen in adulthood because it can lead to the loss of visual acuity and to blindness. Biomedical practitioners see trachoma as a single disease with various stages. When examining an individual, an ophthalmologist will grade the severity of the infection. For those of you who are not familiar with trachoma, it's an infection that causes an inflammation on the underside of the eyelid. The inflammation can be relatively mild, or it can be severe. When the infection resolves, it leaves a scar on the underside of the eyelid. Infections with trachoma does not result in immunity, so a person can get this disease over and over again. The more severe or the more frequent a person gets this disease, the more scarring takes place upon the resolving of the infection. And if there's enough scarring, the eyelid will shrink, turning the eyelashes inward, rubbing up and down on the cornea, which is quite painful. Over time, the eyelashes, which have the tensile strength of steel, scar the cornea, and it's sort of like rubbing steel wool on plexiglass, and create a blind spot. This creates all sorts of important symbolism throughout the Middle East about the eye, the ability to see, and it frames what is normal in terms of vision and so on. Now, preventing trachoma is relatively easy. Once endemic in much of Europe, it was actually a reason that immigrants were turned away from Ellis Island. It has disappeared, mainly because of improved sanitation. Now, one of the places where trachoma is endemic is Egypt. It turns out that while biomedical practitioners recognize trachoma as a disease, as a single disease, local people, ordinary people, do not. In work that we did in the rural Egyptian Delta, we found, for example, that what biomedical practitioners called different stages of a single disease, local people recognized as separate diseases. Rather than being seen as caused by a microorganism, people in our studies saw the separate diseases as having many different causes. Some of those causes were biomedical, some were based on humoral theories of hot and cold, and others on divine intervention. This slide and the next one show you a little bit about one of these separate diseases. and how it's treated. Public health efforts to prevent trachoma have to take into account these various explanations for the disease. Now, some disease explanations link to the issue of identity and to the basic sense of self. And this can be seen in how people think about biomedicine. As in other parts of the world, some people in the Middle East have what is described as a local biology. Working in the Middle East, I often heard that people in the region were different from those elsewhere. Mostly they were described as being extra hardy or more robust. And during research that I did in Egypt, I heard from lay people, biomedical practitioners, and from pharmaceutical representatives that Egyptians were particularly robust and biologically strong. Drug company officials told me that particularly for antihypertensive, antipsychotic, and antibiotic drugs, that Egyptians required larger doses than do the fragile people of the West. And indeed, these drugs are prescribed and available in Egypt in stronger doses than they were elsewhere. These ideas also affect what is considered to be good health care. For instance, a preference for certain kinds of treatments, whether biomedical or local in nature. Thus, in some areas in the Middle East where I've worked, injections have been given a particular kind of power that is not ascribed to the equivalent medication given orally. Likewise, people may express a preference for ethnomedical treatments, such as the ritual of drinking the Quran. This is a ritual in which a sheikh will be consulted about an ailment, and he will select a verse from the Quran that he sees as appropriate for resolving the health problem about which he's being consulted. The verse is then written with chalk or ink on a surface, and it's washed off with water. The person then drinks the water as a way of consuming the Quranic verse and incorporating the barakah or blessings that come from having the Quran incorporated as part of oneself. And this is thought to be a cure for the ailment, or hoped to be a cure. Similarly, when an affliction is thought to be the result of jealousy, what we might call the evil eye, the domain of health and illness intermingles with cultural ideas about social propriety and the integrity of the individual. Now, following the concerns about personhood, dignity, and respect that I described earlier, one of the things that affects health development in the Middle East are different expectations concerning norms of interaction of lay people with health providers, and second, of interaction among different kinds of health providers. In the West, healthcare providers often ask their patients to tell them what is wrong. Sometimes matters of dignity and honor dictate that patients in the Middle East not speak about some things that a biomedical practitioner might wish to hear about, like premarital sex, whether an adolescent is sexually active, or whether a man is having sex with men. Indeed, ideas about homosexuality are not directly translatable between many Western and Middle Eastern societies. And this leads to a challenge not only on the level of the individual interaction, but also it creates challenges for designing public health information and disease surveillance programs. Interactions between health practitioners may also present a challenge. One of my most interesting conversations was over a long dinner with a surgeon who was also on the faculty of a major medical school in Sudan. We were having a very interesting discussion of technology and health capacity and the importance of sanitation and proper hygiene for public health. Somehow, we got onto the topic of operating facilities, at first speaking about technologies, like the newly available surgical laser to which this physician wished he had access. The conversation moved quite naturally to aseptic technique. Then my colleague told me that it was important to have a sterile operating theater, but that things could be more or less sterile. Momentarily, I was kind of stunned. But then I remembered that Mary Douglas, Dame Mary Douglas, recalled her very famous statement that dirt is matter out of place. And her demonstration of the idea that ideas about what is clean and what is dirty depend not just on the observable state of objects, but also on cultural ideas about purity and pollution, some of which are tied to ritual and religion. These kinds of considerations were conditioning the way in which my colleague was thinking about the concept of sterile. I repeat, this person was very accomplished, a leader, in fact, in the medical school faculty. The conversation just underscored that what we do and say is not directly translatable, but is refracted through a cultural lens. And in this case, that lens was at the level of culture as meaning, the why things are done, not at the level of how or what. Ever so briefly, let me mention that for people in the Middle East, the experience of colonialism and of great power manipulation is quite present for them. One can be amazed that the collective memory of the Crusades is so material and present, but one only has to recall the fervor that arose when President Bush spoke about the war in Iraq as a crusade. Or reasonably, one can be aware of the political machinations that brought the present boundaries of the Middle East into existence. Sensitivities about these past events often combine with issues of dignity, respect, and partnership to shape the perceptions of health intervention efforts. Who leads, why it should be that way, and most importantly, what is the more general message received by the way health development efforts are structured, who they engage, and the norms that emerge for interaction between local staffs and local people and international staffs. And I just will recall that during our discussion, I'd like us to consider the effects on polio eradication campaigns that our efforts to find and kill Osama bin Laden have had. But I'd like to give you a final example and talk about Middle East respiratory syndrome, which I believe ties together the things that I've been discussing. And so I'd like to speak briefly about this so that we have time for conversation. The World Health Organization announced in September 2012 the discovery of a new coronavirus and its presence in several countries in the Arabian Peninsula. Persons infected with the MERS virus, as it's called, show symptoms that include respiratory illness with fever, cough, shortness of breath, and breathing difficulties. Some patients experience kidney failure, and especially for people who have comorbidities like immunosuppression, diabetes, heart or lung disease, the risk is even higher. Now, MERS can spread from person to person, but it doesn't seem to spread that easily. So it's been found mostly to spread within healthcare settings and among people who are in close contact with one another. Now, in the spring of 2014, there was another outbreak of MERS, which was centered in Saudi Arabia. But cases were reported in 15 other countries. And by the end of April, 30% of those in Saudi Arabia who had contracted the disease had died. That would be about 105 of 315 cases. There's now a genuine concern that MERS could become pandemic, meaning that it could affect many people over a wide geographic area, both in Saudi Arabia and abroad. Now, in considering MERS, we encounter all of the challenges that I described earlier in this talk. In facing the potential threat of MERS, government agencies and health agencies will have to collaborate effectively with one another, and they'll also have to work effectively with local populations. For horizontal interoperability, there's a need among agencies working together to rely on information that they share and that they can depend on. In the case of MERS in Saudi Arabia, cultural practices make for unreliable information sharing. Two such practices are of note. First, in Saudi Arabia, as in other countries in the Middle East, it's illegal to defame the reputation or position of the state. Unfortunately, this results sometimes in a reluctance to collect and to share information that can be considered as casting, or might be considered as casting, the country in a negative light. Second, the social and class distinctions within Saudi Arabia translate into a healthcare system which has parallel institutions for different sectors of Saudi society. The MERS cases there have been treated in 8 different hospital systems. For example, separate hospital systems are maintained for and run by the Ministry of Health, the Department of Defense, private oil companies, and universities. These hospital systems do not always share information about cases transparently. For vertical interoperability, agencies and organizations confronting the health threat posed by MERS must work effectively with local populations. There, cultural beliefs about disease and its transmission challenge prevention efforts, just as in Egypt, ethno-medical beliefs about trachoma present challenges for control of that disease. Researchers at the World Health Organization and elsewhere have identified the Egyptian tomb bat and camels as non-human reservoirs for MERS. In Saudi Arabia, 2 cultural practices bring people into close contact with bats and camels. First, date cultivation plays a large economic role in Saudi Arabia, and the cultivation involves agricultural workers climbing trees to pollinate them. Bats nest atop these trees. Thus, when a worker climbs the tree, he's exposed to the feces and urine of the bats, which contain the MERS virus, putting them at risk for infection. Now, it turns out that the agricultural sector relies heavily on foreign workers, and that the emergence of new cases of MERS is correlated with those workers being present. The effect of the implementation of very tough labor laws in 2013 was that it expelled from Saudi Arabia many foreign workers, and consequently, the date industry suffered economically, losing almost all of its harvest. But also in 2013, there was no outbreak of MERS. But in 2014, the date industry had successfully lobbied for an exemption from these labor laws, returning the foreign workers to the trees, and a new surge of MERS cases took place. Second, camels play a particularly valorized role in Saudi culture. Camels are an emblem of and a link to the society's valorized nomadic past. Camel racing and the breeding of camels for that purpose are also a big business. Yet many lay people do not acknowledge the link between contact with camels and the spread of MERS. For example, one person commented, quote, "It's true. It's not true. It's a lie. We live with camels. We drink their milk. We eat their meat. There's no disease. We live and sleep and spend our whole lives with camels. There's nothing. There's nothing." Okay? Similarly, even veterinarians, some veterinarians in Saudi Arabia deny the link, relying on government ministry in action rather than World Health Organization guidance as an indicator of the veracity of the link between the MERS virus and camels. One of them saying, "If it were camels, the agricultural ministry would have taken some measures, but they haven't." So let me conclude just by reiterating that there's no easy answer in approaching the cultural challenges that affect interagency efforts to develop health capacities in the Middle East. Indeed, one of the things that is important to remember is that in matters of culture, the usual distinctions we make in planning between strategic, operational, and tactical levels are often blurred. We must recognize that in dealing with matters of culture, it is a complex and dynamic challenge that takes place simultaneously on many levels. Attention to and awareness of these challenges is going to be essential for success in building health capacities in the Middle East and elsewhere. And with that, I think we have 5 minutes left for conversation.
Question, just introduce yourself real quick, Dr. Rubinstein.
Oh, we met already.
Yeah.
This is a fascinating, very complex story. The thing that I immediately think about and wonder about is the cultural connectivity between doctors internationally. Because there is, if one believes in that, there might be, can that be built upon in terms of medical education, doctor education, veterinarian education, if you will, to create those kinds of, I suppose in your case it would be a horizontal linkage to strengthen that as a way to if you know.
I do understand. The way I think about this question is actually framed by my experience with conflict resolution and negotiation. For a long time, some people said culture does not matter at the level of international negotiation because we have technical teams and they're working on technical issues. Technical. So, and then it became obvious that people bring their cultures with them. So I think, yes, it's possible to develop in the horizontal level a common understanding and a common a consensus about what things mean and how they should be implemented, whether sterile means sterile or whether it's a variable concept, for example. I think those discussions can take place, but one has to make them explicit as opposed to assumed to have them bear fruit. Yeah.
Next question.
I'm just curious how you see cultural anthropology shifting and changing as the world becomes more connected through social media, with their generational differences in places that you study like Iraq and Egypt between the young generation who's very active through Facebook and Twitter versus the old generation, and how that is going to affect our interaction with them. It will be more fluid and less of
So actually you started off with a question about anthropology, but then you turned it to the region. So let me just take the second one, because anthropology is way too complicated to characterize. The region's simple. I think that the developments of social media are tremendous. They're going to make for lots of changes in the region. We know, for example, that the so-called Arab Spring, whatever that's become, was energized in a great measure by the use of social media and the trading of information across social boundaries that might otherwise not have been crossed. So I think there'll be a great change. I think it'll be a really interesting anthropological study to collect and examine the content of social media exchanges to see whether the kinds of symbols, the key symbols that I'm talking about, still show up. I was impressed with the Egyptian revolution that the key symbols that were involved in terms of family and so on were reproduced in social media just as they were by Mubarak when he was trying to quell this. So it's going to be a fascinating change. There will be changes. It won't make it any less dynamic. I think it will make it more dynamic.
Thank you, sir. Just one other hand sort of flutter over here.
So what's your first best question? I know this is, outside of your area, but what is your biggest concern with the international response to the Ebola crisis and the biggest problem that you see with China now?
Well, my biggest concern with that would be that would not be in the Middle East particularly. It would be in the United States. I think we're a little bit too self-satisfied with our abilities to deal with this. I guess a couple of weeks ago I was talking to one of my classes about Ebola, and I said, it's going to get to the United States, and it's going to be very interesting when it spreads to Syracuse University, because we will want to quarantine, and let's face it, quarantine in different places has lots of cultural resonances. How do you quarantine in a society where men and women are traditionally kept separate. Anyway, in the United States, we've thought about what's going to happen at Syracuse University when there's an outbreak and we quarantine our students to their dormitories and their parents come up with guns to get them. We don't know, what's going to happen at that point. So I think my biggest concern is that we're a little too self-satisfied here. Yes, we have the capacities to deal with it, but we have to understand the way people interact, because if you just think about the cases that are in Texas now, and the tracing of interaction, that's going to be very, very important. That's kind of inchoate, but it's my concern.
Thank you very much for your time. We got you a little memento here. Keith isn't filming an album of the U.S. Naval Academy. Let's thank you.
Thank you so much. Thank you.